This conference will now be recorded.
Good day, everyone. First of all, thank you all for taking the time to attend this live session organized by Simulid. This will be a live simulation scenario from A to Z, hosted by the Academy of Sciences, Riyadh. In command, we have Mr. Shadi Riyadh, Director of Simulation and Life Support Training, Simulation Educator and MENA, American Heart Association Faculty Territory. We will also have with us Dr. Muhammad Ashur, Pediatric Emergency Specialist, ATLS Course Director and Simulation Instructor, Co-Chairman of the Departmental Quality Committee, and many other qualifications. For this scenario, equipment in use will be Gomar Mannequin Tromahal S3040.100 and the Debriefing Audiovisual Management System BLAN. Shadi, I will give you the floor right now if you want to start the presentation and the live demonstration.
Okay, thank you, Nasreen. Good morning, everybody. First of all, my name is Shadi Diab. As Nasreen introduced me, just let me quickly go through it again. I'm the Director of Simulation and Life Support Training in the Academy of Sciences, Riyadh, Saudi Arabia. I'm a nursing background, a bachelor degree, then a master degree in health profession education. I have a total of 18 years of experience, 8 years of clinical experience, and the remaining 10 years are in education and simulation-based and life support training. Currently, I'm a territory faculty in the MENA region with the American Heart Association. I'm a certified simulation instructor, and I'm a certified instructor with the OPCW, which is the Organization of Prohibition of Chemical Weapons as well. It's my pleasure to be with you today. Before I start, I would like to thank the organizing committee in the 5th African Conference. I would like to thank the Simulid team, Mr. Serene, Dr. Carlos, Mr. Sherbel, Mr. Ahmed, and all the team working behind the scene. I would like to thank the Academy of Sciences team and the team that you are about to see after a while, who are volunteering to make this event successful, inshallah. So before we start, I'm gonna give some introduction about simulation. Of course, simulation, it's like a science. It's a very detailed and very comprehensive field to go through. But maybe some people of you, or most of you, they know about simulation, the others they don't. So let me just conclude it in a few minutes if we can. So what's the simulation by definition? There is a lot of definitions regarding simulations. One of them, it's like the bridge or the way to bridge the gap between the clinical performance and the educational sessions. So another meaning, simulation is when you bring your learners, either undergrad or postgrad, and put them in a very similar area to their clinical area and do the practice dealing with mannequin or standardized patient or any other equipment. And here we start to talk about high fidelity simulation and low fidelity simulation. And we have the mid or medium fidelity simulation as well. So what we mean by the fidelity? The fidelity, it's the degree of realism in the simulation sessions that we have. So what's the benefit of the simulation? The simulation, it can provide the learners a realistic experience, which is very similar to their clinical area, how to deal with a critical patient or any other regular patient based on the objectives that we have. But we have to highlight here that it's in a safe environment and doesn't have a risk on to the patients because we don't have a real patient. Why the simulation is important? There is a lot of studies were announced before showing how the simulation can decrease the medical errors. One of the studies showing that the simulation can decrease the medical errors between 26 to 28, even up to 30% after the simulation training. Simulation, of course, it started a long time back in two main fields, which is the military and the medical field. In the end of 17th century, then started to grow up in the 18th, 19th century. But that time it was very primitive. They were used to use like dummy to simulate a patient or pregnant woman. They put some pads or towels inside under the clothes, and this is part of the simulation. But it was that time very primitive and start to go more advanced with time. So whenever we have simulation, we have main component. It should be there to see that to say we have a simulation session. Of course, based on which simulation center you are in. Is it an academic place like a university and the simulation it's part of the curriculum for the undergrad? So in this case, the components are different. Now I have to go for curriculum development steps. We have different steps we have to follow. Then we'll design it, we'll plan it, we test it, and we implement it again. And it will be a part of the curriculum for a long time. If you are using a simulation for some specific training, it's not for medical students, for example, postgrad. It has, here we call it more scenario design, not a curriculum development. It means we just need to make a scenario related to these objectives specifically, or specific abnormality or pathology we need to treat. So what are the steps to start a simulation? The first step is needs assessment or problem identification, all the same level. Yani, what I mean by this, if you can go for your clinical or your healthcare providers and you assess their performance. For example, you find that the nurses in such department, they need more practice how to assess in chest tube insertion, for example, or how to assess in intubation, or how to insert IV line for infant patient. So we assess their needs and we found a gap or area for improvement. And that time we start to design a simulation training for them. The other one, problem identification. Sometimes simulation, it comes based on some sentinel event or some malpractice. And for example, let's say we have reports that the number of failure intubation in the ICU, it's increased. So here we have a problem. In that point, we start thinking to start or to design a simulation training for the ICU physicians to improve their skills in intubation. So this is the first step, either problem identification or needs assessment. Then after that, once we find the problem, we have to put our objectives. What I need them to learn from the sessions. So once I put my objectives, and again, objectives always should be SMART, now I can put the plan. So based on these objectives, what kind of simulation can fit? Do I need a high fidelity mannequin to train people on IM injection, for example? So it's not necessary. I can use it with only a small mannequin, which is a task trainer. So based on the objective, I can plan my simulation and the required equipment and the fidelity that I need. So we plan it. Now we start to design a scenario. So the scenario, it should start from the beginning. What scenario will give the learners and how the case will go. For example, just let me give you an example, it might be more clear. For example, I design a scenario that the patient comes with a severe chest pain to the ER, so how they will manage him. While they are managing the patient, the pain increases, that patient deteriorates, so then he develops ventricular fibrillation and he's in a cardiac arrest now. So how they will deal with the cardiac arrest. So they will deal with it like a realistic case. Here, I need a high fidelity mannequin because a task trainer doesn't work to give the vital signs and the case of cardiac arrest. So this is how we develop the scenario. Also, developing a scenario itself, we have, if you can go to the internet, you can find a template of scenario design. There is a lot of templates, a lot of guidelines. So you can see it in the internet and you can see what I mean by the steps and the template of building a scenario. What are the information that you need to keep or you need to enter in the scenario design. After we put the scenario and the design itself, what are the mannequin needed and how the scenario will go from the beginning until the end. If the participant, they managed it in this way, there will be improvement. If they didn't manage it in this way, so there will be a deterioration. So we put the design now. Now it's the time of implementation. So the learners will come to the simulation center and we run the training for them. So the scenario or the training implementation, also it has three main components, which are the briefing, the performance, and the debriefing. So, and this is actually what you are going to see next live with us. After a few minutes, we will start. So the briefing, it's like you set the expectation, the ground rules for the participant. You explain to them about the environment that they are going to do the training in, what you expect from them to do, and the time frames, their safety issues, and everything. You can brief them before they start. Okay. Then if they have any queries or any questions, they can ask. It's very important to set their psychological safety. What do you mean by psychological safety? Psychological safety, the people or the learners who are coming for the simulation, they need to feel safe. Safe of what? Safe of being, of doing mistakes, safe of being judged, or safe being embarrassed in front of other colleagues. So all these things we have to clarify it from the beginning. So they have to feel that they are a team and we are all learning from each other. So we will learn from the scenario. We are not judging each other. The confidentiality, it's very important to be mentioned in the briefing. They have to know that all what happened in the simulation and in the debriefing after that, it stays in within this institute or within this training center. And by the way, all the participants or all the learners, when they come to the simulation center, they have to sign a consent form about confidentiality and about taking records or recording, video recording, or taking pictures or photos, because most of the simulation, it will be audio visually recorded inside the station. So consent form, it's very important here. Everybody comes in should sign this form. So we finish the briefing. We will go after that for the performance. So the participant, they should already know how much time they have to manage this case. And we will run the training session. After they finish, we will come for the debriefing session. So debriefing, we have a lot of references, a lot of debriefing styles and techniques. We have the two major families of debriefing, let's say judgmental, non-judgmental, and the preferable one is the non-judgmental debriefing that makes the learner feel more safe about it. So the debriefing, we have, as I told you, we have different tools, different techniques. I really recommend you to go through YouTube and attend any debriefing sessions, regardless what technique or what style of debriefing you are going through, but it can give you about the concept of debriefing. So this is in general about simulation. Of course, to know more about simulation, there is a lot of details. It's like now a fellowship program or specialty. Now it becomes a specialty. So I tried to say the general lines about it in a few minutes. Hopefully I can, if I really gave you or deliver the message clearly, but still a lot of information can be added later on. So now what you are going to see next. Now, in the Academy of Sciences, we participate in this conference as a live simulation session. Due to that time, we cannot go through the first process and the second and third, which is needs assessment. We have the objectives, and we show you how to design the scenario because it's time consuming. So here we will start from the last step, which is the implementation. So what you are going to see next, you will see our team inside the room. We are briefing them about what they are going to do. Then you will see them doing the case management and the scenario itself. Then you will see us moving to another room for the briefing after that. The challenge here, it's everything is live. It's not a recorded session. It's a very challenging, and really it needs, it takes a long time to think about it, to decide to go through it or not, because whatever it happens, you cannot try again. It's a live and one shot only. I always say I don't trust technology, but hopefully nothing will happen. I hope the sound and the picture, it will be clear. Again, it's a live. Try to please focus on hearing the sound. If sometimes the sound, because people are talking in the room with a critical care, with a critical patient, so sometimes it will be noisy environment. Sometimes it will be crowded inside, a lot of people talking together. So please, I need you to set your earphones or speakers in a calm area so you can hear very clearly what's ongoing. We will start our session in a minute. I hope you enjoy it. After we finish the debriefing, you have the chat box in your system. You can ask any question you feel or you want, and we will answer it at the end. Please feel free. After we finish this session, I think this session is scheduled to end around 1, which is already we start late. After we finish the debriefing, whoever willing or whoever doesn't have another session and he can stay or she can stay with us, and you have any questions to discuss with us, we can stay online with you for a longer time after the session ended. So please feel free to stay and communicate with us for any reason, for any concern, for any questions. I hope you, I delivered the message clearly for this short time, and I hope you enjoy it, and I wish you will enjoy what is coming. Thank you very much.
Are we live? Yes, bro. Okay. Good morning, everybody. Good morning. My name is Shadi Diab. I'll be the simulation instructor with you today, and I have Dr. Muhammad Ashur. He is the senior instructor as well. Will be with us for our session today. So, welcome to the Academy of Sciences Simulation Center, which is your case. It will be about a trauma case management. So, just let's brief quickly what you are going to do here and what we are going to do here before we start. So, we are in the simulation center. You will be managing a case of trauma case. In this room, it's like a real ER room. So you have the patient bed. You will have a high fidelity mannequin coming. It's simulating a real patient, and you have a real equipment are available, all what you need in ER. So you will need in this room as it's a real room. Whatever is here, you can use it. And whatever is missing or you need to call from other department, you have the phone line, you can phone and you can ask for any help you want. Okay? So the mannequin, it's a high fidelity and sophisticated mannequin. It can give you the realistic vital signs, realistic anatomical shapes, and you can see the physiology of the mannequin as a real patient. Like the mannequin can breathe in, breathe out, you can see deformities, you can see bleeding, you can see shortness of breath, you can see blinking eyes, consciousness, unconscious. So please deal whatever in this room as it's a real case. Whatever is happening here, you consider it real. Okay? Good. So the expectation from your side, you will be a team in the ER, in a rural area, and primitive hospital. Dr. Sharif, you are the team leader, and you will assign your team members later on how you want them to deal with the case. Okay? So you have 20 minutes time to manage the case. After you manage the case, after the 20 minutes, we can stop the case, then we'll go for the debriefing session. Okay? So here, the sequence, as I told you, we start performance, then debriefing. This is not a test. This is a learning session. Please feel free to do whatever you think is the right thing to do. If there is something we can correct it and improve it, we will do it all together at the end in the debriefing session. So make sure this is not here to judge anyone. We are not here to test anyone. We are here to learn from each other. Okay, as a team, how we can save our patient's life. And this is what actually happens in the clinical area. So your safety is highly important for us. Okay? Again, let me repeat the word that everything happens here, you will consider it as a real. Everything is simulated, whatever can happen. But if you have any serious issues or any safety issues regarding you or your colleagues in the room, please shout loudly. This is not a simulation, we have an issue, so and so. So the word, this is not a simulation, it's our indicator that there is something out of the simulation. Are we agree on that? Yes. Good. Again. So be good to know that. So again, no judgment, no testing. We are here to learn from each other. The time of the scenario, as I mentioned, 20 minutes. The time of debriefing, 20 minutes. Okay. The debriefing, it will be video-based. So once we start the session, actually, we will start recording audio-visually, which is the sign that you, the consent that you signed already that you agree on the recording. So once we go for the debriefing, we might go for discussion, sharing our thoughts, our concerns, and we might review some parts of the video of the performance here, so to see if there is something can be improved. Okay. So so far, do you have any questions? Yes. Yeah. Good. So now Dr. Muhammad will give you the scenario, okay, about the case itself. Once Dr. Muhammad gives you the scenario, we will be out of the room. We will be with you from outside. You will not see us. You will not see us, and you will deal with the patient as it's a real patient, and you are alone. You are a team leader and team members, and you are not here. So I hope you will enjoy the session. I hope we will learn from this session all together, and I will leave it for Dr. Muhammad.
Thank you very much, Mr. Shadi. Thank you very much for your attendance and participating in this simulation. And this is a good experience for all of us, inshallah. So you are the senior ER physician in duty in a primary rural area and in a primitive hospital. And with a bed capacity of 25 beds. No subspecialties available. And the nearest tertiary hospital is about 150 kilometers away. You have 2 nurses and 1 assistant physician with you in the shift. You just received a call from an ambulance team about 1 patient en route to the emergency department, and the pre-hospital report as follows from the dispatch department. A 35-year-old male patient involved in a car accident at speed of 160 kilometers per hour with frontal impact. The dashboard of the vehicle is completely crashed. The steering wheel bended down, and the EMS took a long time to extract the patient, which is almost 40 minutes to arrive and extract the patient. On arrival, the EMS paramedics reports that the patient was unconscious with alcohol smell and responding only to painful strangulation. There is diffuse bruising and multiple body facial abrasions, reported scalp lacerations with left side chest deformity associated with rapid shallow breathing. And there is total amputated right lower limbs below the knee, and patient being boarded, cervical spine was applied, and patient started bagging, the paramedics started bagging the patient with ambu-bagging, and the initial reported vital signs for the patient. Blood pressure is 80/40, his respiratory rate 40 per minute, his heart rate is 140 beats per minute, and the estimated arrival time is 5 minutes. Okay, good luck and enjoy. Be safe.
Simulation started now. Okay, it's okay. The time 5 minutes. Okay.
Okay.
So good luck. See you on the other side.
Be safe.
Thank you very much. Yes, so we are getting a 35-year-old patient who's had a motor vehicle accident, probably impact, and it took a longer time for him to extricate. It was almost 40 minutes. So there's amputation. He has a head injury. Okay, they're suspecting there is left sided deformity as well. So we get ready with our equipment and everything. And we already done our body substance isolation, or if our PPEs are being go. So we just try to take care of the patient. So once the patient came to preparation, we can just take care of the airway, as well as in the case if we need to do some breathing, also we just go ahead and do it.
All right, so we're doing the airway and breathing.
Yeah. So you can assist him whenever he's changing for the things, whatever is needed for you for the airway and the breathing. Okay, so we can just go ahead. And once the patient comes, you will be, the nurse will be taking care of the things. We just send the blood samples. We can communicate for the lab and the blood bank also. We need to send this one blood samples for the labs and the plasma chain also. If it is not needed, we ask the blood bank to keep negative blood also ready so that we can be given. Once he comes, if they have not started IV lines, we connect to IV line and get ready in the meantime.
Okay, it's clear.
It's clear.
Okay.
So
I will
anything?
check my airway.
Okay, please check your airway. Can you, yeah, just communicate with the, I will communicate with the blood bank. So it will be very important. So we just go
we
ahead.
have a backup for the laryngeal
Okay. Can I just, okay. Just need to power up the blood bank in the meantime.
The right is on. All right.
Yes, lab, we just need you to communicate with the blood bank as well. And just get into the, we have a patient coming in next 3 minutes. Hopefully
So
we will
let's
see
make sure that we have our medications ready. Going to need exometry at, depending on his weight.
So we are ready?
Once I find them, I'll give you an estimate and succinylcholine. Let's have the vials ready at least so that we can prepare the syringes, okay?
Okay, all the other things are ready.
All right, my airway equipment are ready.
Okay.
IV medication is ready.
Okay.
I'll also endorse to Muhammad. We're going to be giving probably Tiamidate and subs just for the
ambulance is arriving.
So please prepare me to give it to you.
Okay, so all set?
Yes.
Okay, we just prepare. Once the patient comes in, we try to.
I will hold the head to shift the patient.
Thank you.
Ready?
Years old male patient, and we see with the frontal impact, prolonged expiration.
Close.
Break on, please.
All right.
Okay, break on.
Break on.
Okay,
Okay.
break on.
And you will count.
1, 2, 3.
Okay, okay, please applicate the card there, please, over the table, so that we can just keep it in mind. So that's the application card.
Yeah,
Please
this
give
is
me
the
the
application
on
card.
Okay. Go ahead, please just look for this. Yeah.
Patient was found unconscious in the scene with smell of alcohol. Jesus is 8, and BB is 80/40. He is tachycardic and tachypneic. There is a right lower amputation, and there is deformity in the left side of the chest.
Okay, there is a deformity on the left side of the chest. Okay, you can just see the
See,
patient.
color is
Okay, any other injuries?
patient and IV line.
Okay, oh, there looks like an amputated on the right side. Yes, can you connect it, please? Okay, just check.
Sir, can you hear me? Sir? Okay,
He's not responding.
Responding.
I think he's only responding just something, just painful stimuli. He's responding. I think we need to intubate Dr. Qureshi.
Sure, I'm going to just suction the airway first,
Okay.
and then I'm going to prepare with the medications.
Okay, I think
Yeah, suction.
Okay, Dr. Monitor is at cash.
Okay.
Okay. Heart rate is 140, blood pressure is 80/39, respiratory rate is 40, and saturation is 80. But temperature,
suction, okay?
Okay.
but temperature is 7.5, and we have one scanner on the left side, and I'm going to insert a new one on the right side.
Okay, please go ahead.
Suctions.
Okay, just send them that for the surgery.
21 milligrams of etomidate and 150 milligrams of salts.
Okay, I think there is no chest press on the left side as well. It is
Okay, we're going to be taking some time to lay with the airway since we're getting the medications. Can you please help me with the breathing?
Okay, definitely I'll just check on that one. Can you just look into that? Okay, please can you get ready for the chest tubing? Okay, we just need the equipment, get ready. Please, can you help me? Yes, please.
Alright, can you please just make sure the equipment
Can you just give me the
it's a size 7
for the
tube.
chest tubing
Just make
session?
sure that it's working.
Okay, can you
Alright,
just look
and
into
it's
it?
deflated.
Okay, I'm just looking in the chest. 1 minute, auscultation.
You ready?
Yes.
Okay.
Okay, decrease breath sounds on the left side, please. I think we need to take, just we'll look on the percussion.
The headboard, can you please remove it? You can hold this, I can remove
Okay, in
it.
the meantime, quickly. Yeah.
What investigation do you need, Doctor?
Yeah.
What exactly do you need for the
We need all the grouping consequences and all the investigation for the lab.
Okay.
Okay, while you get in the line, you'll be starting the fluid.
Yeah.
Okay.
Please lubricate it as well. Let me know when you're ready.
So, I think there is, just do the percussion.
Okay, now.
It is hyperresonant. I think I need to get a chest tube for this patient. I'll just get the tube in.
Open the seat collar so you get a better
Okay, that's it.
I'll continue just remove this, put it down, open it. Thank you. Are you holding? You ready? Okay.
Okay. Okay, can I just get into the plate? Into the scalp plate?
Okay, I am here.
Yeah. Please, can you get the scalp plate?
Scalp.
Okay, thank you. Okay. With sterilization, please, we need to just clean it. Okay.
Okay.
15 to 40 space, we are going there.
I'll hold the neck. Please close the seat collar and get me the CO2 detector, please. Love it.
Yeah, somebody can help us just quickly there, hold the thing. In the meantime, okay, just
Thank you.
I think we need the hyperoscillate. We just need the reading, please. Yeah. Okay.
Can someone else also take the chest when you're done, doctor?
I will check. Oh, there is a gush of air coming in. So we need 22.
Stethoscope for auscultation, doctor.
Yes, please.
Saturation is still 80. Blood pressure is 78 over 40.
Okay, please can you get ready? Okay. Just insert it.
Do we have a CO2? We don't have any detection.
Inside CO2 still not showing the monitor.
Okay.
It's 40, 40.
Okay,
Can you get the...
All right, we're in the airway. That's good. Let's stabilize it to the side.
Okay.
Okay, just please can you get the dressing so that we can stabilize it here and just connect it to the... Okay, this connection of here is coming. Okay. Yeah, just please. Okay, what about the applications? Can you just check on it, please? How many liters of fluid have you started?
Okay, we done with 1 liter.
Okay, done with 1 liter. Still there is patient. What is the blood pressure now?
Plated.
Okay,
Blood pressure is 78 over
okay,
59.
just look for any bleedings, please.
Okay.
Okay, okay, so still there is some source of bleeding. Can we just have it?
I will expose.
Okay.
We have some laceration.
Okay.
Okay, and we have this one that we will break.
Okay. Any other source of bleedings, please?
Yeah, there is a head blast.
Okay, head laceration and minor injuries. Okay, can you check the pupils in the meantime?
I will. Can you take over?
Okay, saturation picking up now is 91.
Okay, saturation is 91. Okay, so fluid system not going. Can we connect the injury?
Okay, I will connect another one.
Yes.
Okay.
Okay, so we just next get into the. Okay, thank you. Okay, then I think we need a tourniquet. Please get the tourniquet. So we need to place. Still there is a source of bleeding. In the meantime, can we have the fast also?
Okay. I will give the fast.
Pupils are equally reactive.
Okay.
They both seem to be around 5 millimeters.
To 5 millimeters.
Okay.
So
Fast.
can we just do the fast please here?
Okay.
5 centimeters, my God.
Okay, I'm just checking on the right side.
Yeah, I'll just get a baseline GCS as well. The patient was not responding earlier,
Yeah.
so we'll give him a 1 for verbal.
Okay.
He's opening his eyes. Okay. Sir, can you still hear me? He's not
just
opening at all,
just
so that's
doing
1.
the, yeah.
All
Let
right.
me know the GCS total later on. Okay, I'm trying to see. No bleeding here, just left on the left.
Okay. His GCS is around 3.
Okay, no fluids. We'll try to do the suprapubic. Okay.
Okay, tourniquet connected.
Okay, still what happened? Still the blood pressure has not picked up. I think did you request for the blood, please?
Okay.
Okay, just ask for the blood pressure.
I will try to call them.
I think we're going to need to start all negative then.
Okay, we're going to get that since
I've also noticed in the head that there might be some bleeding.
Blood is not ready yet.
okay, blood is not ready yet.
Maybe we can get some gauze.
Yeah, please go ahead and apply some gauze to stop bleeding.
Okay, I'll try to stop the bleeding on the scalp and see it.
Okay.
Okay, there seems to be a laceration in the scalp.
Can we communicate
direct
with that
pressure.
hospital so that it will be easier for us? So I think we cannot take care of this patient. Already we have stabilized his airway. Okay, then saturations are picked up now to 90. So we just go ahead and just bag it and please okay, then we just look into the. Okay, we just finish with the airway. Okay, we finish with the breathing.
The
We finish with the
GCS, like I mentioned, is 7.
yeah. Still, I think we need for just please communicate or we need blood fast so that we need to start blood so that we can pick up his bleeding. What about the bleeding? Did we stop?
Yeah.
The
Okay.
bleeding is stopped.
Okay, can we
cover the patient to prevent hypothermia?
Can we connect a Polish catheter please in the meantime? Polish catheter to be attached to the patient. Okay. Okay, stop. We'll just do the rebandaging.
Okay. Still bleeding, so I'll just try to bandage it.
Okay, please go ahead.
Make
So blood pressure is low. Okay, blood came.
Fatima, do you have a bandage that I can use?
Yeah.
Thank you so much.
can you just try to put the bandages wherever just to stop the bleeding, please? The bleeding has been controlled now. Cholestatic energy. Okay, there is good bilateral chest air entry. Can we just have the stethoscope to auscultate and find out, please?
Yeah, here we are.
ET tube is still cloudy and misty.
Okay.
And it seems to be in a good
Blood coming out?
Set up here. Set up here.
So we need the blood so we can already. How many liters of IV fluid has been given?
Now we are done with 2 liters.
2 liters. Okay. So let me check.
I will take another sip to vital signs.
Yeah, please.
Okay.
I'm auscultating.
Full cap in place.
Good bilateral chairs. Just air entry is there.
Right?
Yep.
Alright.
Fully static
Oh,
away?
yes.
Okay,
Let's
thank
just
you.
use these for now. To stabilize it.
Okay, blood carrying.
Still not
Okay,
yet.
did you communicate with the receiving facility so that
Yes.
we can just need to transfer the patient?
Okay.
Since we don't have any
Yes, I
subspecialty,
did.
no x-rays.
Yes,
Except
yes,
the
I did,
part-
but we wait for their approval.
Okay, just check it out
Okay.
again whether they got approval.
Blood is here.
Okay, okay,
Good,
thank
good,
you.
we have blood.
Yes, we have.
Okay, in the meantime, again, we reassess the patient. Any problem with the airway?
Again, it's misting.
Okay.
She's ventilating. Can we slow down the ventilation a little bit? 1 every 5 seconds, please.
Okay, auscultation, we can see there is good chest pass whenever she is bagging. Bilateral good air entry is there. Okay, we'll just do the
What
abdomen.
about the trachea? Would you like to check the trachea?
Oh, we should have done it earlier before.
Okay, let me hold the mesh for you.
Yeah, please. Yes, okay. Okay, I'm trying to check the trachea.
Okay, blood is running.
In place now. Okay, we'll just put back the collar. Okay. So did we communicate? Please just check with the communication with the hospital. Tell them this thing. We'll just refer this patient as soon as possible. Okay. So there is good air.
We're going to definitely need a chest X-ray for
Okay.
the patient.
Ultrasound fast is fine. There is no injuries.
What about the chest tube?
Extremities except amputation.
Is there any blood from the chest tube?
No, there was no blood from the chest tube. Only here was
Okay.
just came out. Okay. No, there is no other. Can we just log roll and try to just do the examination of the patient?
All right, I'll handle the head.
Okay. Yeah.
We'll disconnect this.
Can you
Because
just
the hospital, they are saying that we should contact them and just to give them endorsement.
Okay, sure, sure.
I will do the one. Okay.
One second.
Yes, wait, okay.
One second, I'm going to have to remove this. Please stand back.
Okay.
I'm going to hold the head on my count.
Okay.
We're going to move together, okay?
Okay.
1, 2, 3.
Okay. Okay, please. Okay, we'll just check the spine. Okay, there is no injuries. Can have the gloves for the PR, please. Okay, done. Okay, no blood, no nothing. Okay, fine. We'll just throw the gloves.
All right,
Okay, so
let's handle back. Let's go
okay,
handle
please
back.
continue back, please. Okay, I'll just communicate with the hospital. I'll just be in communications. Can you, Dr. Qureshi, can you continue with patients for secondary assessment if you have time?
Sure.
In the meantime, I will just try to
secondary
get
assessment.
the information.
All right, so we're going to have to do, do you know anything else about the patient? If he has any allergies or
He is alcoholic.
just alcohol right now?
Yes, it's
Being shifted to
Okay.
he is not allergic to any medication. We don't have this information. There is no voice sign.
vital
There is
signs
no any
slowly picking up now.
Okay, we're going to have to try and find the relatives eventually.
140 blood pressure.
So that's the history. I'm going to take a look at the head. Nope.
Respirations.
There seems to be, just to stop us from the scalp,
low.
there's a wound on the cheek, so no non-occlusion,
Communicate.
no deformity.
Assessing
The
out.
nose. Okay.
Laceration.
I'm going to check
We are suspecting
the
injury.
pupils again.
Intubated. And there is good
Blood pressure start rising.
Collar is fine.
How much is the blood pressure now? Now it's 94/70 with an R of
In the
78.
meantime, we are trying to.
We are done with the flight with the half liter of blood.
In the ice
The
box.
map is good for now. I think we need to give another O-negative.
Okay.
We can order another O-negative to go.
Okay, ready? The paramedics along with that one and the Dr. Khalid will accompany with the patient. Okay, thank you.
Okay. Fundoscope seems fine.
Yes.
No signs of toxin or any issues.
Okay, the
inside.
blood pressure has picked up now? Okay.
Yes.
Okay,
There's
go.
no crusting of blood in the nose. All right, I'm going to have to do a neck examination, or
Okay.
are we ready to
So what
transfer?
about
We
the
are ready to transfer. They asked us to transfer this patient.
Okay, so I think it's just safer to keep him on seat color and all of that.
Okay, what about saturation? Saturation is 90.
We're going to have to take oxygen with us.
Do you think we are hyperventilating the patient with 1 breath every 6 seconds?
So let's try 1 breath every 6 seconds now. Okay? His EtCO2 is fine for now, yeah. But his saturation I'm not happy with. Let's just check the tube very quickly. Just to make sure, and can we auscultate again, please?
Yeah, sure.
Okay.
Now the saturation is 93, 94.
Okay, saturations have picked up. Okay, the tube was displaced.
All right, so I already adjusted the tube now.
Tube always, okay. You just check saturations have picked up
so
now.
if you want, just hold it up like that.
Okay, good chest air entry.
Good.
Good chest air entry.
So I'm going to be going with the patient. I think we're going to need to prepare for the transfer.
Yep.
Do you want to give tetanus for the patient just because of the injury?
Yes,
let's give some tetanus.
Okay. What's the order for the tetanus?
How much would you like to give him?
Okay, it's 1 ampule.
Just 1 ampule. So we will give, I'll take the oxygen mask with me, extra oxygen, an extra endotracheal tube with the extra laryngoscope, so set for intubation. Since we're going by land, the chest tube is already there, which is fine, but I'm going to need a backup tube.
Okay. Definitely, just make arrangements for you.
Alright.
Can you just make
blood? We're going to need blood for this.
Okay, for the chest tube in case if you need to.
It's how many kilometers? 150?
150.
So it might take us like an hour and a half to get there. Maybe we need like 2 units of packed RBCs, so negative, to go with us.
Yep.
And
we can do the second
and another 20 just in case. And
we are in the middle tourniquet.
The tourniquet already has been stopped now. So the exposure, so blood pressure has picked up.
That's I think all we need. Yep. And then we can start to transfer the patient. On the way for the ambulance, I'll continue my secondary survey. But if it's possible, let's get some blocks.
Okay, so blocks, please. We can just make
arrangements so it does not move at all.
Okay. Such blocks are arranged.
Okay.
Okay. Tetanus was given.
Good. Alright, let's prevent hypothermia, guys.
Because since he has an open injury, we can
How's his temperature? 37.5
also.
37.5. What's antibiotics you do? I recommend just cephalosporin 30
Okay, go ahead, please.
We'll give around cephalosporin and give him 1 gram of cephazolin.
Okay.
And we can cover the gram-negative with gentamicin.
Okay.
Alright.
Please just make arrangements and we'll start and we'll just come.
We can also endorse it to them over there if we don't have it. Because I don't know, the last time I checked, we may not have it.
Okay, anyhow, we will just endorse to them in the process. Okay, any other things?
Okay.
Is the ambulance is ready for transporting for this patient?
Yes, there's.
Can we just, do you think that we need a nasogastric tube or OGT?
I think because of all the facial injuries, we might consider OGT for the patient.
Yeah.
Right? So let's put an OGT.
OGT tube, please.
Yeah. I will bring it. I will.
In the meantime, let's review the adjuncts.
Okay.
We need ECG monitoring, portable on the way.
Okay, fine.
As well, just to make sure. How is his ECG right now?
Sign is just starting.
His blood pressure is improving, saturation is okay for now, 95. Okay. Let's slow down the respiratory, give half the bag.
Okay. The phone, take the phone. Pick the phone.
Hello? Yes. Okay, we are ready.
Yes, we are with you. You can send your patient.
Okay, please.
Thank you very much for your patient is stable now.
I'm going to go.
Thank you.
So let's get the stretcher. Let's go back to the ambulance.
Okay, simulation session, and thank you very much.
Thank you.
Thank you very much.
Thank you very much, everyone. It was stressful to watch. So the debriefing session should be starting soon. Just the time for the team to to go to the debriefing room. Thank you again for the team member of the Academy of Sciences, Riyadh. Shadi, you want to start the debriefing now?
Yes. Hi, Nasreen. We're just finished. I hope the sound, it was clear with the noise and everything because it's a live again. Now we will move on to the debriefing sessions, as we mentioned earlier. Before we move to the debriefing, so now in the debriefing, as I mentioned earlier, we are going to highlight the area for improvement that it happens, and actually intentionally it was done during the scenario because we need some area for improvement to talk about it in the debriefing. So I think our audience now, they will see how we can run a debriefing session after the performance. So I will see you in the debriefing. Thank you very much.
Thank you, Shadi. So we will wait a couple minutes for Shadi and the team to be in the debriefing room. In the meanwhile, we are accepting questions in the comment section. I have seen that some have trouble to log in on the meeting, so I'm assisting people to log in on the meeting. See you in a couple of minutes. Thank you.
Okay, our audience, we are going live now in the debriefing room.
Okay, thank you everybody. It was a good session, interactive and good learning environment, I think. So I wish you enjoyed it as well, and I hope you are not tired. So let's go and to see what we learned from this session. How do you feel first? How was that?
Felt great. It was really nice. Felt very good. Okay. It was also very scary at the beginning, just because we're thinking real patients and everything. But I think we went through it smoothly, as much as we could, and we worked well as a team. So I also want to thank the team members as well.
Okay, good to know that. Why do you think it was scary at the beginning?
I think it was just mainly at the fact that you're getting ready, adrenaline, for the patient to come in and working together, and it's the first time we work really together. So I think it went well actually.
Exactly, and this is one of the objectives actually to work as a multidisciplinary team. So thank you for that. Congratulations. Dr. Sharif, what do you think about, was it scary for you as well?
No, it was not scary because I have a very good team to support me and just work on that. So we went through the things smoothly because there was really communication was occurring through my team members. They were trying to just support me, and whenever I need them, they were ready to support me as well. So that was a good thing in the process of learning.
Yes. As a paramedic and something you became as part of the team, how do you feel that it was this experience?
Actually, it was very good because this is what happened in real life. When there's when in a hospital the leader needs more members, the paramedic can jump in also, and just not also in trauma patients, also in critical patients. So it was great.
So Riyadh, thank you very much for you as a junior physician, and all of a sudden became as a nurse in this role and this simulation. Any difficulties that you face in at this, let's say, preparation or even in the interaction?
Yes, maybe some devices new for me this first time to see the simulation patient scenario. And I will ask help for a physician. This is the benefit of the teamwork.
You have confidence now to face the real trauma patient?
So thank you for that. Let me just highlight this point or ask this point. So do you feel it's okay to ask help, or you feel shame if you ask help in a critical care case? If I have something I don't know how to do it, or I'm not expert with this skill, for example. So how do you feel about asking help from colleagues, not only from the team leader?
You have to ask for help.
Because our priority is to save the patients, not to feel good for ourselves.
Exactly.
Let's keep integrity inside and let's save the patients.
So now you feel like you are working as a team to save this patient's life, but you're not working alone to save his life. It's all a team.
Yeah.
All of us together.
Good.
Mr. Muhammad, teamwork, you think that if we're going to run this session again, anything you would like to add before we start as a preparation for our real case, let's say, as a part of the team?
Okay, absolutely. What I have noticed in that scenario is that we have shortened hands, especially for documentation. So maybe we can figure it out by asking the team leader that if we have a documentary person who will take responsibility for documentation. This is the first thing. The second thing I have noticed during the scenario, and I'm going to read the same scenario again. I have received one order, it was not clear. So I was shy at that time to read or to clarify the order from the physician. It was about the antitetanus. So just a mention for that antitetanus was given, but the dose was not clear. At that time I was shy to say that again. Could you please repeat the dose exactly? So I think the team dynamic somehow a little bit was not clear for me.
Okay, about tetanus toxicology, you mean?
Yes.
Which is being given, and it's at the end of the session. What you can say as a team leader?
Yes, I had to give a proper communication, which I was not much clear on that. So I think there was a lack of communication from my side related to the dosage. So since I was not aware, I should have asked him what needed the dose in case needed to get the help. So it's no harm to ask the other person to know what is the dosage to be given as well.
I agree with Dr. Sham, because it's life-saving, and sometimes we have to clarify the order and going with what we call the closed loop communication. That means Dr. Sham, as a team leader, giving an order to the team, we have to be sure of two things: that the team member receiving the order clearly and showing the response to the team leader. Yes, I got it. I such dose being given to the patients. Okay, we'd like to go through the video sharing.
Yes.
And we have some.
We can we will review some video parts now to see our performance, how was the session, and if you think it can be improved, yes or no, and if yes, how we can improve it. But before we see this video, so can you tell me briefly what did you learn from this session? What's something new for you? You get it out of this session?
To communicate as much as we can together, rather than to yourself. Sometimes you find yourself just talking to yourself and not making sure that you direct it to.
What else this session added for you?
He said we need to, make sure that we listen to the order carefully and correctly. So I think we missed close communication.
Okay, anything else you want? Thank you. else you want to add?
Just again back to the communications. I think we need a bit of more good communications with each of us. So to make us better care for the patient, there was some delay I felt on the as a team leader. So maybe we have to improvise more on the communication skills within each of us. So that may be the major issue which we have to concentrate on.
Thank you. So I think so far we all agree on one point that we can improve our communication skills during the recitation phase. Do you think this is applicable in real life?
Yes, absolutely. And I can add one thing, that the preparation in the briefing, I felt that I'm familiar with the environment, the equipment, and because I was underestimating the preparation. So if I will repeat the same scenario again, I will take more time and be familiar with the environment, the equipment that I have created.
So, you mean the briefing, it puts you at ease and you were feeling safe and you know what are your expectations to do?
Yes, absolutely.
So let's go for the video now. We'll use some footages and we will discuss it together.
Two things that we like to highlight it here. First, I think it was a noisy environment to some extent, you think? Some people talking, and even at certain time, and the endorsement from the paramedics was not, I think, clear for me at least. Somebody's talking here, somebody's talking here, I will take, I will do. And one thing is also the positioning of the team leader. And do you think it was a proper position?
No, it should have been near to the legs of the patient. It should have been. Since maybe I thought that I need some help in case if it is needed, so I was just nearby.
So why do you think the best position for the team leader on the leg side?
Because he can just monitor from all the people the team what he's doing.
Exactly. So the team leader needs to monitor the patient, the team, and the monitor and the patient screen as well, everything. But in case needed, the team leader to jump in and back up some cases, you have to go there or not. What do you think?
Yes.
You have to practice that. So it's not that this is the ideal place for a team leader, but when needed, if he needs to move some time there and back, it's okay if we need to do something.
But since we are very few people as a team, so I thought that maybe we need my resources as well to help them take care of the patient.
Okay, let's go through that here. And we'll see, it's almost. Dr. Qureshi, do you think that the intubation is being done in proper time, or do you feel that there was some delay?
There was a delay, definitely.
Okay, what do you think the cause behind?
I think it may have been the fact that the equipment themselves may have been new to Riyadh. Perhaps I should have spent more time in the preparation to orient her towards maybe knowing exactly which of the equipment instead of assuming. Also at the same time how to handle the bed as well. Because we mentioned we were ready, we made a decision for intubation at the beginning. We suctioned the airway, we gave the oxygen, but the actual process of the intubation itself was delayed because of these things. So I should have spent more time working with her and orienting her at the beginning after we've been briefed by the team leader.
So how, thank you, but how would you avoid it in real life, in your clinical area to happen again?
To know the team members that we're working with, to know their limitations, and then after that, try to encourage them to learn.
Okay, good. Anything else you want to add about this point?
I think for me, we should have done, since patient came because it was urinary issues, we should have removed this piece on the head side earlier itself rather than wait. So like, I had to just move, I was trying to take care of his breathing part and then have to just go there to pull it out and help the percolation. I think we should have been a bit earlier.
Yes,
so it should have been
So we go back to the point of preparation, and this is good for dispatching always when the paramedics or the EMS people at the clinic patient dispatching, giving you exactly the expected injury and giving you the primary sign for the patient, alcoholic and just responding to clinical stimulations. We assume that this patient will need intubation, so our instruments, our medication should be ready, so we can just go through it in that. Okay, one more thing which is important also here. Let's go.
Okay, I'm going to just do the pause please here. My sense. Okay, I'm just checking on the right side. I'll just get a slide. Okay, so patient was not responding earlier, so we'll give him a 1 kilo promo to release oblique spines.
So what do you think about the position here of the team members as a team? Anything can
be spread out a little bit more. The team leader, now that he's done, could go back to the foot of the bed, allow us to be one on the head, 2 people maybe on the sides, and 1 person at the leg when they were working on the leg itself. But it was a little bit crowded. I was checking the GCS at that time and trying to relay the information as well.
Exactly. So this is the point here. It's the crowded environment. So how you prevent it, or how you can avoid this to happen? If you can see here, we can see one member on one side of the patient, and all other members on one side. So it might cause distraction for us when we are working together with a critical care patient. So how you can, again, always we think now, and we think how we can improve it in our real life. So how do you think we can improve it?
So that's why the room should be in the end of the patient, So when he sees a lot of crowd, he will reassign the room. He organizes the team members properly.
So based on your point, Farma, to assign the team members and so on, do you think any arrangement in the room settings, the equipment, it can help you later on to be easy access from both sides, on different sides?
Definitely.
So what do you prefer to change here?
I like the position of the airway equipment, but we could also add the breathing if we need the chest tube close by, just so that we don't have to go all the way to the back and do it. Maybe the monitors could be pushed a little bit backwards to give more space. And perhaps the table that had that equipment could be brought maybe behind the team leader rather than to the wall onto the side.
So to give you space to move and be already distributed in different areas around the patient. So the best way to do it when? During the resuscitation or before?
Before.
Exactly. So it should be well prepared before. let's say it happens and it wasn't prepared for some reason. And you have a critical case and you have a patient and you have the settings which is you're not comfortable with. What do you have to do?
You have to communicate to the team.
Yes, exactly. If we are able to do it without delaying the care of the patient, it's better because giving ourselves or putting ourselves in destructive environment, it will affect the patient management. Yeah. You agree on that?
Yes.
Yes. Good. Thank you.
Okay. This one is Muhammad point, and I would like you to just highlight patient. Okay. Muhammad, 2 points. First, Dr. Hisham Abdul Sharif, he asked you for blood transfusion and starting blood for the patient before. And after a long time, he recalled asking again if blood was not transfused. What do you think about him that time?
I was trying to call the lab, but they said at the first time they said that the blood is not radiated. The second time I forget to reply for him that the blood is not radiated. So just a little bit delayed communication, I think. Maybe later we need just to improve the communication.
Okay. The other point for preparing for transfer. What he mentioned to you, Dr. Hisham, that time?
To call the admin, the hospital admin to arrange for transfer, but they say that the physician should call us just to give an endorsement on the case and not the rationale for transfer.
Excellent.
So just I replied to him that the admin want you to call them to clarify what's the reason for endorsement.
I think this is the standard way that physician to physician communication, and we have to, at this time, when we are preparing for transferring the patient, we admit and we address the life-threatening issues first, and we have to be sure about our findings for the patients, that this patient having so and so. So we give them a full detailed report for a stable patient, and giving them our requests and going through the ASPAR communication way, which it should be properly. So I have to call the proper hospital with the proper facilities and in a proper way for communication, right? So next time if you've been in the same situation, what do you think that we can do more?
Okay, if I need a policy on that I cannot endorse. So from the beginning, I will inform the team leader that I don't have the privilege to endorse such patient. You should do it. Absolutely, I will use the mutual respect as one of the team dynamic elements. So I think this is what we should do next time.
Do you think it's really matter this small things to do it or not, or how it will affect? So if the team leader didn't call and assign someone else, which is maybe this is not the protocol used, why you think it's serious or it's really important?
Because it will delay everything. So, and the patient is critical. We will not save the patient as soon as we want. So that's why we should.
So every single issue when we are stating a patient, it matters. It matters. Any behavior we can do inside the station, it can affect either positively or unfortunately negatively to the station process.
And that's reflected on the delay of the transfer of the patient. Exactly. And as we mentioned always, every hospital has one vicious bit sometimes. So we have to convince them for our patient that it's needed for this day. Okay, just focus on this action. you think it's the only thing?
Yeah, that's
We delayed it.
You interrupt the ventilation,
yes.
right?
Well, to be fair, if I may, at the beginning when you're going to log roll, especially for the position that we've been having, if we had a better positioning, we could continue. But at this sense right now, we didn't expect the log roll to take that long into coming back and everybody coming back into position. So we should have arranged our positions a little bit better and the room first. That way we can minimize interruptions as much as we can.
So positioning, even they prefer no cross hands in the maneuvers or in any interaction in the no cross hands while you are handling. Even you are backing, you have to be comfort, not the other way. And that's exactly what's happening. You interrupt the ventilation for this patient, and always knowing that we interrupt the interaction, the patient is breathing, and after that you will start from beginning, from 0 point, which we don't like it to happen. So this is a critical point also, and it could affecting the patient outcome and the patient situations. Okay? Okay, and I think here, yes.
Aspect now? Yes. There's no prostate of both of the nose. Alright, so we're going to have to do an neck examination for so what about any plans for the also supervised by this patient? Yes, I think it's just safer to keep them. I don't see color or all. What about saturation? Saturation is 90. I'm going to have to take oxygen with us. Do you provide ventilate the patient with 1 breath every 6 seconds? So let's try 1 breath every 6 seconds now. Okay? His ETCO2 is fine now. But his saturation, I'm not happy with it. Let's just check the tube very quickly. Just to make sure. And let's put it again, please. Here we go. Okay. Now saturation is 93, 94. Okay. Saturation is not picked up. Okay. The tube was alright. So oxygen. I already adjusted that. Saturation is not picked up now. Okay. Good gesture, maybe. So I'm going to be going with the patient. I gotta go ready to prepare the transfer. Do you want to use Methodist for the patient just because of the injury? Yes, we do. I will. Let's have a match go for the test. How much would you like? It's 1 and 2. Just 1 hour. So we will get. Alright, I'll take the oxygen.
Okay, the last one through it was and that's what mentioned by Muhammad first, that the dose of corticosteroid was not clear, either IM or IV. Also, this is an important point. And one important thing is that you already plan for transferring the patient, and you mentioned to them that your patient is stable, but you're still rechecking the patient if he is deteriorating or not. 2 things we'd like to highlight. After any intervention, please check the outcome of your intervention. How was the situation and how it is now, okay, to show that, to see the improvement. And from the other point, when you are free, and because we find sometimes that we are standing and we have nothing to do, okay. At this point, we have to utilize it in rechecking the patients, because not there. If I activate the patient, maybe the patient it's blocked, the tube it's blocked, obstructed, it's locked, or whatever could happen. I am not sure that he is secure 100%, so I have to recheck it again from time to other. Examine the chest. Be sure that my patient is stable all the time. So no post time, I think during resuscitation, you can utilize it in the better way. Mr. Shadi?
Yeah, I think good point, valid point, because as we mentioned before, we are trying to simulate a real life. So we don't think that in real life we have a critical case patient and we have some time just standing doing nothing, because always we can do something. In such case, as Dr. Muhammad mentioned, assessment and reassessment is very crucial in such case, because your patient might deteriorate at any time. So reassessment and reevaluation frequently, it's really required here. So who do you think can do the reassessment and reevaluation?
The team leader should direct some of the physician to go ahead and reevaluate all of the management that was done. But I also think that if we had a documenter at the beginning, they could also pick up what's going on the monitors to help the team leader. So if there's a deterioration, that alerts us that I need to start the re-evaluation process and tell the team leader what is going on after that.
As a recorder, you mean?
The recorder checking and helping the team leader and letting him know, okay, something's dropping or what was given and things like that. That way it will prompt us earlier to reassess and more organized reassessments.
How about the team members? Could you do that as well or not? If you find some findings or deterioration or whatever, any signs, so should you communicate it to the team leader as well?
Yeah, members should inform him if there are any deterioration of the vital sign or anything happen to the patient.
So again, we'll go back to the first point, it's a teamwork. Yes, so yes, we have team leader to organize and to direct or to lead the sessions, but the patient's safety and patient's life, it's our all responsibilities altogether. So yes, we need to communicate together, we need to emphasize the important point, we need to do the job done as well. Okay. So after all, let's recap. Any other points that you want to add so far before recapping?
No, thank you very much for them. All the time, even in real life, there are always gaps. And as far as these gaps affecting the patient's life, patient outcome, we have to avoid it as much as we can. And our role from simulation here is to make it a habit, to do it in a proper way, and to avoid these such actions. And to work as a teamwork, and it should be as a symphony that everyone is working together and understanding how it should run proper way. That's all.
Okay, so let's recap. What do you think is the take-home message after the debriefing now, after the scenario and after our discussion?
Communication.
Excellent. The first point is
communication.
Effective communication. Effective communication through clear message, clear assignment of roles, okay? Close loop communication,
Constructive feedback.
constructive international feedback, exactly something
Knowledge
needs to be
sharing.
done.
Knowledge sharing.
Knowledge sharing. Summarization and evaluation important elements in the communication. So, because sometimes if we are running a long case or we have a critical patient for a long time, we might be lost what we have done and in which step we are. So re-evaluation and summarization as a team, it's really crucial and important. And maybe the team leader here, we can, as a team leader, I can share the current status often with the team. Okay guys, now our patient, he was so and so, and now he's still alive, vital signs improved. Okay, let's focus on this. And so this summary, it make everybody on the same track during the session. Good. So good point, communication. What else?
Documentation also. So we needed was, if the person was there, we should have summarized what is happening, you should have given us the feedback related to the improvisation or deterioration of the patient, so that is also really help us out. Since once we are in the scenario, we get lost. So we are thinking and we are running it maybe. So he's the one who is looking at what is happening, and he will help us out by summarizing what is happening or need to change the track if they're not going in the right direction.
Exactly.
So it will be a good guide for us.
So documentation is again important in terms of timing for the management itself, for the medication, for any procedure, documenting what was done and what was not yet done. And aside of the importance of documentation in the recitation itself about the patient safety, it's also important for the legal issues after the recitation. So the recorder or document, he's the one that the others will rely on him or her to make the final reports based on what we documented during the situation itself or during the recitation itself.
Also, one more important thing, knowing the capability and of the teams. I will not assign someone who's not expert in any branch or any service to apply it. And yes, all the time the team leader is the backup for any action, and he could interfere at any time when he feel or even the team member announced that I couldn't do it or it's difficult for me, it's his role to interfere. But since beginning all the time, we would like to assign a proper person for proper action.
Due to the points that we discussed already, like you need to go for early transfer for the patient because this case is crucial for preparing blood to give blood and so on. So what's the take message here for you as a team or team leader or team members?
For me, it's teamwork is very, very important. And next point is early communication to the receiving facilities, since we have limited resources and limited capabilities. So we need to communicate early with the receiving facilities and communicate. As a physician, as a team leader, I should have communicated much into the picture rather than sending somebody else. So that is what I do.
So excellent. The idea here is, as we mentioned, always think ahead of time. So I have to anticipate what's going next. Okay, because my patient is in a trauma. Once I start the management, I start thinking about, do I have OR or not? If he needs OR, do I have ICU or not? Do I have the procedures needed to manage this patient or not? So thinking ahead of time gives you a chance to make the process faster. Okay, good. What other take-home message? Another take-home message?
Preparation.
Excellent. Excellent. Very, very important point. As much as you are prepared, as much as the outcome will be better. Short and very little preparation will give you, unfortunately, a poor outcome and poor performance. Good preparation, as we mentioned, even training and rehearsal, that's why we have the simulation. That's why we have the training. So now if you work together as a multidisciplinary, when you go in real life, you work as a physician, with a nurse, with a paramedic, with a RT, you know how to work together. Why? Because you are done the training already and you are prepared. Preparing the settings, preparing the room, preparing the environment, it's really crucial. Totally agree. Anything else you want to add?
The preparation also includes position of the team members and proper allocation of the spaces that we have.
Excellent. Good. Definitely. Anything else? So thank you very much. It was a very interesting session. I think we learned a lot today. Thank you for participating in this session. Great effort, great performance, and it was a good team. Thank you very much.
Thank you very much.
Thank you very much.
Okay, thank you.
I will. Okay, I'm back to you, Nisreen, again.
Thank you very much. It was very interesting, really, to see how the debriefing session went. I think, sorry to interrupt you, I think any participant who wants to ask question, Shadi is now available to answer your question. You can go ahead and unmute yourself, and Shadi is available to answer any question you might have.
Yeah, actually, Nisreen, thank you very much for coordinating the events. I would like, before we start the question, to thank the team. Really, they did a great job. They were volunteering to help and to participate in this session. Dr. Muhammad Ashur, Dr. Sharif, Dr. Gurashi, Fatma, Dr. Riyadh, and Mr. Muhammad. They were with us the whole time. And we can stay for a while if you want to answer the question for the audience. If they have any question or concern, they need to discuss it. We are here for a while. I'm staying with you.
Yes, thank you, Shadi. Thank you for all the team members. It was a great job, really. Very interesting to watch. So we have a few questions from the comment section, and I think if you want also to open your mic and ask question directly, you can go ahead. Feel free to open your mic. There is a question from Najib. He was asking about, in fact, the simulation setup and the trauma setup. What materials you have in your? Sorry, let me get back to the question. if you have in your emergency crash cart trauma equipment and accessories ready for the simulation scenario.
Sorry. Yes, I think I have to turn the camera off because I need to put the mobile